Hello, everybody, and welcome to today's unveiling of the 2025 watch list of the top technologies and issues related to artificial intelligence in healthcare. My name is Chris Camel. I'm the Director of Health Technology Assessment here at Canada's Drug Agency, and I have the pleasure of being today's moderator for this exciting conversation. Bienvenue au dévoilement de la liste de veille 2025 des technologies et thèmes à surveiller dans le domaine de l'intelligence artificielle. Je m'appelle Chris Camel et je suis le directeur de l'évaluation des technologies de la santé à l'Agence des médicaments du Canada. J'aurai le plaisir d'être votre animateur aujourd'hui. Next slide, please. I'm speaking to you today from Ottawa, which is located on the traditional unceded territory of the Algonquin and Anishinaabe Nation. Thank you to the Algonquin and Anishinaabe Nation, who have been the keepers and stewards of this land for thousands of years over many generations. I'd like to encourage you all to think about where you live, work, and play. Take a moment to acknowledge the peoples who traditionally occupied, who sustained, and who continue to care for the land you call home. Next slide, please. Before we begin our conversation, just a few housekeeping items. During the moderated discussion portion of the webinar, we'll be taking several questions from the audience, so please submit any questions you have at any time by using the Q&A tab in the Zoom control bar. The watch list report itself can now be found on our website. After this event, we'll send an email to all registrants with a link to the report and to the recording of this session. You'll notice when you go to the website a focus on the web experience, and so a big shout out to Jeff Kirwan, Lindsay Kirkup, and our IT team for creating a really engaging digital design for this work. Next slide, please. Just by way of disclosure, our organization is funded by the federal, provincial, and territorial ministries of health, with the exception of Quebec. And we do receive application fees from the pharmaceutical industry for our reimbursement reviews, as well as our scientific advice program. Next slide, please. So this is the agenda for today. I'll begin by introducing our panelists and then provide a brief introduction to the 2025 watch list, including how it was developed and the 10 items on the list. After that, we'll head into a discussion about these specific items and what it could mean for health systems across Canada. Next slide, please. So today I'm thrilled to be joined by an amazing and diverse panel of experts. Joining us are Dr. Amol Verma, who is a physician and scientist at St. Michael's Hospital, Unity Health Toronto, and the Temerity Professor of AI Research in Education and Medicine at the University of Toronto. Amol co-founded and co-leads Gemini, Canada's largest hospital clinical data research network, which includes 30 hospitals in Ontario. We're also joined by Donna Rubenstein. Donna is a patient partner committed to advancing the integration of patient and community voice in all aspects of healthcare. She contributes to innovative projects in health research and service delivery. Donna currently co-chairs the Patient Advisors Network, PAN, a national independent community of practice for patient caregiver partners. And we're also joined by Monica Field, who has more than 33 years of experience within the government of Saskatchewan. In her current capacity at the Ministry of Health, Monica is leading the development of a provincial digital health strategy, along with the roadmap to implement this strategy across the health sector in Saskatchewan. A key pillar of this work will be artificial intelligence and how its applications will benefit key health system delivery in the years to come. Next slide, please. And so this slide and the following slide include disclosures from myself and our speakers. Thank you. And next slide. And so for those of you who may not be familiar with our watch list, it's an annual report that forecasts 5 emerging technologies and 5 issues that have the potential to transform health systems over the next 5 years. For these lists, we use a broad definition of technologies, which includes medical devices, diagnostic tests, clinical interventions, and models of care. And the issues under consideration have to be ones that cross-cut the broader scope of care and that can impact how these or related technologies are developed and adopted in Canadian health systems. The list itself is meant to be impartial and is intended to inform health system planning in Canada. While older iterations of the watch list highlighted top technologies that spanned a wide range of clinical areas, in recent years we've been trying to focus on individual themes. Last year's theme was care for children and youth with medical complexity. This year's focus is on artificial intelligence, an often suggested solution to tackle issues faced by the Canadian healthcare system and to revolutionize healthcare delivery. AI is expected to affect all aspects of the system, from public health planning and disease diagnosis and prognosis to clinical documentation and other administrative processes. The 2025 watch list spotlights the top 5 AI technologies and the top 5 issues that may arise with their implementation. Next slide, please. So in terms of the development process, the watch list is a unique example of work at CDA. It's an example of co-creation by a diverse range of contributors. An advisory group of external experts guided the overall direction of our work, including providing input on a short list of approximately 20 items identified by Canada's Drug Agency from the published literature and industry news. The final 10 items were selected using a modified James Lind Alliance approach to facilitate consensus in a priority setting session in November of 2024, which involved patient partners, healthcare providers, policymakers, and more, including our 3 panelists today. There are a lot of people involved in the creation of the list, and I want to specifically acknowledge our internal team, Caitlin Ford, Nazia Darvish, and Chikwi Hao, who held the pen on the report, Tamara Rader and the facilitators who led the priority setting workshop, and Sarah Jones, who's been the quarterback behind the scenes for all the work. I'd also note at this point that while the watch list items are numbered, they're not ranked in order of importance. So the 5th item, for example, is not more or less important than the 1st. Next slide, please. Thank you. I'll now cover in brief the 5 technologies and 5 issues contained within the list, and then pass it over to our expert panelists who can discuss in more detail the value these technologies could bring to our health system. Specific examples of each technology category can be found in the full report. So for our list, the top 5 AI technologies in healthcare are AI note-taking. AI-powered note-taking applications are used to transcribe conversations between patients and healthcare providers and generate clinical notes. Implementing AI for note-taking could potentially decrease time spent on documentation, and accurate note-taking could enhance health outcomes and improve patient experiences. AI tools to accelerate and optimize clinical training and education. AI tools to accelerate and optimize clinical training summarize available evidence, provide general background knowledge, and can provide trainees with the latest evidence regarding interventions. Using these AI tools could potentially transform current medical education, enhance the learning experience, and improve training efficiency. AI for disease detection and diagnosis. AI technologies such as machine learning models can assist healthcare providers in improving disease detection and diagnosis based on various data. These tools may improve health systems by enhancing diagnostic accuracy and making advanced diagnostic tools more accessible. They can enhance care pathways through the early identification of diseases or conditions. AI for disease treatment. AI technologies for disease treatment offer a new way for patients to access the most appropriate and effective treatments. Artificial intelligence can assist by determining the best medication, dosage, and treatment plan for each patient. They can support a more efficient and sustainable healthcare system and improve overall population health by focusing on the most appropriate and effective treatments. And AI for remote monitoring. AI technologies for remote monitoring can collect, analyze, and interpret patient health data remotely and provide real-time data to healthcare providers in other locations. These technologies can improve community-based and home-based care by prioritizing the needs of patients, caregivers, and healthcare providers, thus enhancing clinical outcomes and patient quality of life. This can expand access to healthcare, especially for those in remote and rural areas. Next slide, please. And now on to the top 5 issues that warrant attention if health systems are to realize the full potential of these technological advancements. So the top 5 issues identified by our panel related to AI technologies in healthcare are privacy and data security. AI in the healthcare system can learn patterns from health system data, but there's concern about how this information can remain private and secure and exactly how it will be used. So for example, a 2024 survey of physicians in Canada showed that 21% were confident about AI and patient confidentiality, whereas 79% were either not confident or unsure. The workshop participants stated that there's a strong need for privacy guardrails related to the use of artificial intelligence in healthcare. Liability and accountability. AI in healthcare may include interpretation of data by artificial intelligence as well as humans at various stages, raising potential issues of liability and accountability. So, for example, it can be difficult for healthcare professionals to understand how AI systems come to certain conclusions because they don't control the development of the AI system functionality. This interplay of AI and human decision-making can lead to questions about accountability and who is ultimately responsible when AI is used in care. Data availability, quality, and bias. AI in healthcare requires a high volume of data to train algorithms and to generate new information. The limited access to information between jurisdictions and different health systems makes it difficult to establish large data sets. The data used by AI should also be of high quality, and poor quality data can cause direct harm to patients. Bias or lack of representation in a data set can also result in AI systems perpetuating existing social biases that can cause inequities, discrimination, and inaccurate decisions. Data sovereignty and governance. The use of large data sets in AI systems has led to discussions about who should own and manage the data. Data sovereignty refers to the rights of a group of people to control their own data, including how it's collected, stored, and interpreted. Data governance defines who has the authority to control and to manage the data. Designing AI systems and their data sets requires working together with equity-deserving groups so that they have control over their own data. And finally, environmental costs. Although the use of artificial intelligence in healthcare can offer numerous potential benefits, its environmental impact is a significant concern that can't be overlooked. AI systems use high amounts of energy due to data centers that run on electricity and require large amounts of water for cooling. They also depend on the extraction of rare metals to build the necessary hardware. Developers and the healthcare systems need to work together to balance the expected benefits to patients with the potential harms to the environment to make sure that AI technologies are sustainable. And that's the 2025 watch list. So now I'm delighted to move into what I hope you'll find to be an engaging discussion with our expert panelists. Again, you can submit your questions by clicking on the Q&A tab in the Zoom control bar. And so to kick things off, I'll maybe start by directing our first question to all three of our panelists, related to the items on the watch list itself. So can you maybe talk a little bit about one item from the list that resonates most with you and why? And we'll start things off with Donna.
I'm going to push back a little. I'm not going to pick one. What I'm going to say as a patient partner, I feel like a couple of things I want to say is one is I picture a future where patients are full partners in their healthcare, and I see each of these, everything on the list, even going to 10, as being a part of supporting that kind of model, and that's being a full partner with their healthcare team, and as well as being involved with research, policy, and services. One thing I want to mention, when I looked at the list and I was preparing and thinking back, the interesting thing for me in looking at the technologies and the issues list was a thread of it was the human factor, and how we implement AI will be a big part of determining its success. So it's not just about technology. Each of these has different elements of technology, but it's about people, culture, and change management, like on a really big scale. And the exciting part, despite all the challenges, we have a lot of knowledge and research around change management and past systems change to draw on. So I'm excited about that. I'll stop there and give somebody else a chance to add in.
Amol, any items from the list that particularly resonate with you, or anything about the process that we undertook to get there?
I'll take Donna's lead and avoid answering the specific question. No, maybe I'll offer a brief reflection on. I think the list does a really nice job of balancing some sort of lower hanging, more immediately implementable tools and technologies like the AI for note taking, with some of them which I think there are immediate and exciting opportunities for efficiency and saving some clinical time, but which in themselves are not going to address the critical challenges facing healthcare, right? Which are about access and better care and addressing sustainability and all of these other challenges that we have, right? Whereas some of the other items on the list, like AI to improve disease detection and diagnosis so we can get earlier treatments and prevention and help people stay healthy instead of ending up in hospital. Like those remote monitoring, like similarly keeping people out of hospital, those are much more aspirational. And I think that's what's nice about this sort of 5-year window is there's a bit of a portfolio in here of sort of some quick wins and things that can get out the door quickly, and then more aspirational work. And if you don't mind, I might just dive a little bit deep on the AI for note-taking piece to illustrate how a couple of things that we know and don't know about AI today. We know with certainty that some AI tools will be very useful in medicine. There have been large-scale randomized trials showing that AI can help us with the diagnosis of breast cancer and reduce the amount of time that radiologists spend looking at a mammogram in 80,000 women in Sweden. And there was like a 44% reduction in radiologist screen time. So we know conclusively some tools can be very useful in some contexts. What we don't know at scale is which tools are useful and how. And sometimes those answers are actually paradoxical. So let me give you the example of AI for note-taking, defined a little bit broadly. One of the biggest challenges of managing the modern electronic health record is managing the clinical inbox, the interaction between patients and clinicians and their care team when questions come up. And so a lot of the advanced health records have an inbox where patients can ask their care team questions. AI has been used in 2 ways. One way was using AI to generate automatic replies to patient queries in the inbox. That would seem like it might save clinicians time. Like if AI can generate me a reply, it'll save us time. Well, in a study at Stanford, that tool saved 0 minutes of time. And only about 20% of clinicians actually liked using it. On the other hand, an AI tool that was focused on streaming those messages to the right clinician. So it just classified, hey, this is a message for a nurse. This is a message for a physician. This is a message for, another member of the care team. And triaging, urgent, must be seen now, that kind of thing. That tool saved time and reduced the number of messaging interactions required in the record. And so I flag that as a way of saying, and that was implemented at Emory. And so what I do, I flag that as a way of saying, what we think might work might not work, and another way might work better. And we're in this really exciting moment with AI where we're testing these new technologies as they evolve, and learning how they can work and how they can help clinical workflows and clinical care that's being provided. And so what I'm most excited about in the next 5 years is that process and the role that a critical agency like CDA can play in the health technology assessment part of that, so that we are investing our scarce public dollars in the technologies that will work, and scaling up things that will work. And so that is what I think I was most excited about with the watch list.
Great. No, thanks for that. And yeah, certainly part of the watch list is trying to separate that hope from the hype. And I think we'll probably throughout the conversation circle back to how we actually do that with AI technologies, especially with the amount of press they're getting these days. Monica, I'll go to you, and I guess I won't ask you to pick on a specific item because that doesn't seem to be where we want to go. But if you can maybe comment on the list itself, how you might use it in your work, or any reflections on the process as you were involved in it.
Yeah, thanks for the opportunity to speak, and with my colleagues on the panel too. It brings a blend of really what the spirit of this watch list was. I won't speak to one in particular, even though knowing in Saskatchewan we have geographically dispersed populations that could benefit from some of the the aspirational initiatives that are listed in the watch list. I think for me, it really isn't. It comes down to education and awareness, not just for the healthcare provider, but for the population, in understanding that these tools are here to help assist. And I use the example of, like when we talk about AI scribe in the report, and the ability for a physician to be able to speak and have a conversation with a patient and make eye contact. And it's about connection. We as humans need that connection. And when you have a physician whose panel and the workload is so high, and you want to try to get the information, that attention to the human connection side sometimes, gets lost. So I see the value in that, but it's about understanding, how patients and healthcare providers can use this tool together. It's about having guiding principles as well, because we know that there, even as we sit here, there are tools that are being developed, exponentially, and making sure that, it's not a matter of whether we're going to be using these tools, it's when. And just making sure that there's guiding principles to help not only the patient, but again, the healthcare provider know and understand accountability and the responsibility of the use of the tool. And then I'd say third, it's about setting priority. Both my colleagues on the panel talked about that, but it's about investing the dollars where we need to be able to make the biggest impact on healthcare. And I think that's going to be, that's the exciting time that we're living right now, is how can technology help our HHR, like our human resource strain, and are there other methods to be able to help with that? So thank you.
Great. Oh, thank you very much. We're starting to get some questions coming in from the audience. And so one of them is related to personalized medicine. And so a few years ago, our watch list was actually focused on personalized medicine, but this question is related to sort of the data component with AI. And maybe I'll direct this to you, Amol. How well do AI methods do at developing personalized medicine for like racial or ethnic minorities, especially given sort of challenges with representative data in that space?
Yeah, thanks. It's a really a very good question, and I think there's a few different parts of it. So first, there's just how well do they do with personalized medicine, and then the sort of equity angle and the representativeness angle to it. We know there, like again, definitively in the literature around AI, we know that AI algorithms can propagate biases that exist in our data sets. And so when we're thinking about evaluating AI algorithms, we have to ask ourselves, okay, well, what were the data that were latent in the algorithm, in the data sets that were used to train that algorithm? But also biases can creep in not just because of data, they can creep in because of the way the algorithm was trained. So perhaps the most famous example is one where AI was used in an American insurance network to predict which patients would likely need more healthcare services. And as a proxy for healthcare need, they used the cost of previous healthcare received. And the big problem is that some people have barriers in accessing care. And so in that specific study, what they found was that people who were Black were historically underserved by that healthcare insurance network, healthcare provider. And so the model systematically underestimated the future healthcare costs, which are a proxy for need and a poor proxy for need, of people who were Black, and therefore triaged resources away from Black people, if used in the real world. And so, bias creeps in many ways, and it's actually a really critical argument for why Canada has a really important role in developing AI technologies. So AI technologies that are developed globally tend to be developed where the data are available. And data tend to be available from individual institutions, and in the case, or individual jurisdictions. In the case of countries like the United States, those tend to be limited to insurance providers or healthcare networks. And those healthcare networks, access to care in those networks is limited to who has insurance, right? And so they tend to exclude people who are not insured. On the other hand, data sets from Europe, particularly the Scandinavian countries, which have amazing access to care, socialized coverage of an entire population, much less diverse in their population. So if we think about what Canada can offer to this space, Canada is the single most diverse high-income country in the world. And we have healthcare providers across our provinces that have a single public provider for care, so that we don't have those exclusions to who gets represented in our data. Now, I don't want to pretend that there are not challenges with who is accessing and receiving care in our data. And in fact, perhaps the biggest problem in Canada is we don't have good data about people's race and ethnic background and socioeconomic status. That just is not well captured in our data sets. But it creates an enormous opportunity for Canada to be developing AI solutions that are more representative of global populations, that are more inclusive. And in fact, that is the work that my research network is doing. So, you mentioned Gemini collects data from, more than 30 hospitals across Ontario. That's greater than 60% of the patients served in the population. And we're expanding now and starting partnerships with Alberta and with Quebec and elsewhere. And I think really we have to work together. And this moment of patriotism, of breaking interprovincial trade barriers, gives us, I think, an opportunity to make a compelling argument for breaking interprovincial barriers to doing more inclusive, more equitable AI technology development as well.
Great. No, thanks so much for that. Does, Monica or Donna, I don't know if you want to comment on the data personalized medicine angle. Otherwise, I've got more questions I can go through. No? Okay. I do want to pick up on the example that you raised, Amol, about the insurance companies, because I think that particular example, because trust is like a really important factor with the adoption of AI. And, for every good news story about a breakthrough, you might see another story that sort of highlights some of the risks. And maybe I'll start with you, Donna, but I'd like you all to maybe comment on this. How do we go about building trust for patients, providers, caregivers, or clinicians in adopting these technologies, like given sort of the landscape that we're in where, there's some great news stories, there are some challenges that are raised, and trust is essential for people in their access to healthcare.
Yeah, that's a big question. It's a great one. I do want to say, I think, as you mentioned, it's not just the public, it's across the board. It's people working in the healthcare system as well. Trust, I think a big piece is, part of it is transparency. It's a term we use a lot, but transparency from beginning to end. So it's and Monica mentioned before, I think that comes in the form of education. And when we say education, I think of it as we need to start now. It's not, we tend to do things like we design packages or programs, and then we roll it out and say, here it is, and here's all the user guides and the instructions and PDFs and links. But we need to bring people in earlier in the process. And I think making people having them part of the process. So there isn't this mystique and mystery about it. Because right now, as you mentioned on trust, I don't think you can open up a newspaper or a social media channel without there being something about a problem of trusting government, health, and the whole misinformation, media, and that trust piece kind of carries through the whole population. So it's a big one. But I think transparency and sharing, and I'll mention one other piece is finding ways for there to be choice and alternatives in the process. I think we have to, it isn't a one size fits all. And that's going to be a big piece of, I think, in terms of, you say, uptake or people adopting it, because I'll keep coming back to the implementation. You can have the greatest technology and you can have it in a pilot working great. And then when we go to implement, it's the how that's going to make a difference. And I do think that's where the transparency and education is going to come in.
Maybe I'll go to you, Monica, with the same question. Like, how do you see building trust for patients and providers?
Yeah, I think it is building really that partnership with the healthcare provider and the patient themselves. Obviously training and education on the use of the tool is going to be very key. And, Donna, you spoke to about choice. Not everyone's going to want to have this as an option, and being able to empower the patient to be able to decide, for that will also be key. And honestly, time is going to provide that trust and transparency. Right now, there is such a growing need and demand for just the basics of healthcare in the country, and using this tool to be able to help both the provider and the patient be able to understand the health journey, will be so key. So I really do think that education and awareness needs to start now. Everyone, not just technology people, not just the providers, not just, it's everyone in the ecosystem needs to understand what AI is going to do to be able to help deliver healthcare.
Chris, I
Amol?
want to add
Sorry, go ahead.
one quick comment to say, I think a part of doing that, now I'm going to put my patient partner is having patient partners part of the process in the design and the planning. I can't say enough. It's not something we've traditionally done. We traditionally, something is designed, a program or a product, and then we say, here it is, what do you think of it? And it's 90% of it's in place. So it's like the house is built and you say, well, you can choose the paint colors kind of thing. And it's just limited what you can do. And I think we're seeing in some areas of healthcare, it's still early, where we're bringing patient partners in. This process is a good example. Patient partners have been involved all along. And I think it will make a difference in terms of building that trust and understanding where are the opportunities to build it, because it will take time. But how you do that, I think, that's where integrating the voice of people with lived experience early on right from the beginning.
I want to come back to that point, but first, I'm just going to ask Amol if you'd like to weigh in at all on the trust question.
Yeah, perhaps controversially, I'm going to say I don't think we should ask people to trust AI, because we don't ask people to trust medications, like, period. Do you know what I mean? Like, if I came to you and said, do you trust medications? You'd say, which medication? For what? Why? Right? Why should we ask people to trust AI? We should not. We should say, do you trust this AI tool to accomplish this specific task in this specific context, right? And so we should be taking because there are some AI tools we absolutely should not trust, and some AI use cases that we should not trust, or some organizations using AI that we should not trust. What I think is interesting and challenging, first of all, I totally agree with everything that Donna and Monica have said around engagement and transparency and all of that in the specific contexts. Let me tell you just a little story. We developed an AI tool called ChartWatch that predicts patient deterioration in hospital and sends early warning signals to clinicians. And we deployed it in our hospital, and it, we found in our evaluation that it reduced unexpected deaths in our units by about 26% compared to previous periods. We then did a qualitative evaluation asking clinicians, and we literally asked the question, what was your experience working with ChartWatch, right? It was a sort of semi-structured interview. What was your experience working with this? Did you like the technology, etc.? The answer generally that we received from clinicians was, I find ChartWatch to be useful. It will not replace me. And we didn't ask that question. We did not ask, nor did we intend for ChartWatch to replace clinicians, the doctors or nurses. So what's interesting about that is they were hearing the question we asked, what was it like to work with ChartWatch, knowing what it's for, but answering the question that's in the headlines in the news, that AI will replace doctors. AI is as good at doctors at X, Y, or Z, right? Like so they were responding to the public discourse around AI. And I think and when we do a similar study about, do you trust, what's it like to work with this new MRI machine? No one ever answers, oh, the MRI machine works pretty well, but it's not going to replace me. Like, no one feels the need to say that part. So when we think about trust, especially with healthcare providers, I think we have to think about the prevailing narratives around AI outside of the narrow use case. So I'm kind of contradicting what I said in the first place, that there's sort of context and narrow trust that we should be seeking to enshrine in the right moments. But we also have to do that recognizing the broader global conversation that is happening around AI, that AI may lead to large labor disruptions and changes to the way people live their lives, and that AI is not a neutral set of technologies. AI is a culture. It's a series of companies that have vested interests. It's high-profile people that lead, and so all of those things affect the way we might trust this, our ability to interact with this industry and set of technologies. And so I just think we have to be conscious of that as we look to enshrine trust. And that's why the points Donna and Monica made about transparency, about early engagement, et cetera, are so important, because we shouldn't be asking people to trust at face value.
Thanks for that. Donna, yeah, I'd like to come back to the point you made about patient engagement and involvement in, sort of throughout the full life cycle, including design and other components of AI development. So as a patient partner, you've been involved in quite a few different projects. Is there anything that we need to be thinking about differently or doing differently in that engagement when it comes to artificial intelligence versus, say, a project focused on a pharmaceutical?
I think what I would propose for people, there's a large audience of people involved in healthcare today across areas. And so I don't think of it as just AI separately, because I think AI is tied to healthcare reform. We do parse it off in the discussions, but as Amol was saying, I think even with the trust thing, we talk about trust in healthcare system. It's not just AI. There's issues around that. I think the learnings that I've had is this is new to the healthcare system. We've heard about the term patient-centered care, which is a bit of a hot button for me, I'll be honest. We've been talking about that for 10 years, and it's kind of the top of every healthcare system is their vision. And I think that we're starting to we see now patient-centered care is more patients as partners in their care. These AI is going to help us I say from a patient point of view, be able to be full partners and better manage their care. So in terms of the design and the implementation of AI, whether it's a process or a program, it's critical that we be a part of it early on. That the thing that comes to my mind is a lot of people in the system working on these things, I'll be frank, I've not been used to working with patients in this capacity. They're used to it as a clinical a participant in a trial, and that's more the receiver of something. And so there's kind of a culture shift and a mindset shift in recognizing that there's expertise, there's value to patient partners being brought in early. So it's a change in a way of thinking about doing things. I'm reminded my prior life was in the oil and gas industry, and many 30 years ago when we did projects, we would go off and a group of people would design a plant or a facility, and then bring it all to the environmental folks and the community folks and say, what do you think? And then we shifted to, when we moved into the area of sustainability, we brought everybody to the table at the front end. And I would just say it took a number of years. It was really uncomfortable. And I'm seeing that in some groups in the healthcare sector because it's new. But once people see the value, it's no longer just, oh, this is something I have to do like a tick box to get my grant or my funding. But there's true value, and everybody will benefit. I took a few extra sentences there, I hope. I'll leave that.
Chris, do you mind if I just jump in super quickly?
Sure, of course.
On that point, to say one of the things I really appreciated in the way that CDA developed this watch list was the involvement of patient partners or in the consultation process. I just really enjoyed being part of those conversations, appreciated the perspective. I think that really shaped the discussions that we had in our groups as we were considering the different, technologies. I mean, we started with a much longer list than what you landed with, and I just thought it added a real richness and value to thinking about the priority setting.
No, thanks for that. Monica, I'd like to come to you. And so one of the things that we talked about sort of earlier was the data and the fragmented data across Canada, 13 healthcare systems. How can we ensure that like those 13 health systems in Canada like adopt the same evolving technology standards? And how do you think about sort of that interjurisdictional conversation?
Yeah, thanks for that question, Chris. I think the biggest part is there is work that's underway already with the federal, provincial, territorial group that I sit on, particularly on artificial intelligence. And, part of it is setting up guiding principles, looking for early adopters in being able to deliver and make sure that, because there's another party involved in this, and that's the vendors. The vendors in healthcare also need to play a key and critical part in making sure that the interoperability between systems is there and that we have data standards set up, because, one of the things with AI is if you have a poor data construct, that information has to go in somewhere and it may not link to where it needs to. So the vendor community plays a pretty big part in that. And we've been doing a lot of work in making sure that that vendor community does work towards interoperability. So there is work that's going on today to be able to help deliver AI across provinces and share. And I think that patriotism and the work that's going on now because of the situation we're in, really does help catapult some of these conversations further and being able to make sure that we're able to deliver for citizens across Canada, not just in each jurisdiction.
Chris, could I jump in on that same point? I think it's so important. I wanted to flag two or three specific observations around this. The first is that we don't need new legislation to improve data sharing and improve interoperability. And I think oftentimes we get bogged down in the complexity of it. But really, especially because there are new technologies that help us overcome some of the barriers. So the one I would point to is federated analysis, where historically, in order to analyze data, you need to move all the data into one place, and you needed to be able to run your algorithms on the data in one place. But distributed analysis or federated analysis, what that means is you can have data sitting in multiple different places. For example, a data center in every province, and you can run an algorithm that starts learning over here, then the algorithm moves, the data don't move, and it keeps learning over here, and then it keeps learning over here, and it rotates around until at the end of the day, you have an algorithm that's been trained on all the data, but you haven't had to move data across provincial boundaries. And that technology creates a beautiful path to achieving the Pan-Canadian Health Data Strategy, where it really is recognizing that there's a province-forward approach. Each province should be encouraged to kind of adhere to some common standards, but then we can actually learn and participate and collaborate with each other without a need for new regulation. And let me just give two specific examples about why that's so urgent. The first relates to rare diseases, and this links back to your point about personalized medicine. In order to do personalized medicine, especially for realizing AI technologies that can, for example, help us with early diagnosis of rare diseases, which individually are very rare, but collectively are very common. So something like 10% of all Canadians have, like somewhere between 5 and 10%, have a rare disease. So and the problem is if you only have one province's data set that you can work with, or worse, one hospital's data set, you can never create an AI algorithm that can do that. But if we are able to pool our data, we can absolutely create algorithms that will result in earlier diagnosis, better treatment for rare conditions. And that's so urgent and important. The second one is clinical trials. You need large samples to run clinical trials. And I think as we know from the pharmaceutical industry, clinical trials are so important for our standard of evidence for what technologies we adopt safely in healthcare. between 2018 and the end of 2023, so five years, there were roughly 100,000 global clinical trials of drugs. How many clinical trials do you think there were of AI technologies? 86. Okay. So like a tiny infinitesimal amount. And how many of those happened in Canada? 1. We need to have integrated digital infrastructures so that we can easily run large-scale clinical trials of AI technologies. I'm not saying we need to slow down the adoption. We need infrastructure that lets us rapidly test and safely evaluate these technologies. And that's where there's a huge opportunity for interprovincial sharing. So I want to say just that there's urgency. There's opportunity with technology that makes it not so, we don't need to be so stuck. And to Monica's point, there's a moment of opportunity right now. So I really hope we can make a move on this.
So when we had the workshop, you might recall that the group of workshop participants was like really really interested in making sure that planetary health was mentioned, and including that environmental consideration, which is one of our 5 issues. Maybe I'll start with you, Monica, but I'd be interested in everybody's perspectives of like how do you see that being like managed, I guess, like from a provincial perspective? Do you regulations around the environmental impacts of new technologies like in AI, or are there other ways that can be incorporated? Because like environmental is a big issue that's beyond any sort of one actor, I think, but would be interested in your reflections on that particular issue. And maybe I'll ask everybody to comment on that one.
It just took me a second there to get off of mute. Like I'll go back to what Amol talked about, a little while ago, is about, making sure that we're using AI where there's, there are benefits and not, the risk towards maybe AI won't work in the way that we need to. That's thinking consciously about how are we going to apply AI. And the clinical trials really are where we can start to see those benefits, and measuring the environmental impact on those, as much as looking at, how does this benefit in healthcare? I think that is one measure we need to do. The other part is, making sure that I think things are starting to advance too, where the environmental side over time may balance out. But it is about thinking consciously about how we're using it and whether or not it will benefit over time.
Go ahead, Donna. I see you've
well, I was just going to say, I'll continue on here. I also think there's a foundational piece, and I'll go back to, is I don't think we completely understand what the environmental impact is. So I think there's a need, and this would be at a national level, getting better at the measurement. So when we say, what is the environmental impact? What does that look like? So if we're even looking at an AI technology, we know now, like with pollution, we've gotten better at models. We talk about footprint, people, there's, as an example, making people aware, you send an email, do you realize, how much impact that has? Or with litter, like there's a lot of stuff out, let's say, that we can draw on. But we need to do that work, because I don't think we don't have that in place. So I think that work is going to be important, so that we can actually say what compare different models, or what does this mean? And also that's where I think federally there'll be a need to look at what incentives are there to be more energy efficient, because there are ways to encourage, and that that's into grants and credits and things, but we first have to get a better handle on that. I could go on about that, but I think it's important work, and we do need to, because as everybody said, the AI world, like, it's taking off, whether we like it or not. So let's get a handle and be able to manage that part, because what does managing it even mean? What are the targets? So some baseline work needs to be done. My
Yeah,
two
I'll just maybe add to Donna's. But first, we're lucky to have Donna and her background in the energy sector in this conversation. But I would say that a couple of key points. So one is it's really challenging to measure, in part because there is not a universal truth to how energy intensive an AI algorithm is. In part because it depends on the electricity grid of where it was developed, right? And so there's a lot of complexity. There's also complexity because the technologies are changing. So, a current GPU uses a different amount of electricity than previous. The cooling technology is changing. So we're moving to new types of liquid cooling. And so there's a lot of flux. But the importance is, and I think Donna cuts to the point, we just need to say this is important and enshrine some measurement and some targets in the process. And you probably need a regulator or an external body to do it, because it's not something that an internal, like, will happen in a sort of just altruistic, self-regulated kind of way. One point I will make, which is more of a scientific point, which is that there is a bit of a distinction between the energy required to train an AI model and to use an AI model or apply an AI model, with the training part tending to be a bit more, in some cases, much more energy intensive, particularly for the large frontier AI models like the ChatGPTs, the Geminis of Google's, et cetera. What's exciting though about that is that there is a world in which a large energy intensive investment is made to train a highly capable model. And then you bring the model into your environment and you can tweak that model so that you're just fine tuning it to accomplish a specific task in your new context. And that doesn't require all the energy from training. So there is this really exciting world of what they call foundation models. So you build a foundational AI model and then you use it for multiple narrower purposes that I'm hopeful will help address some of these environmental issues. But I think it's really important that CDA put it on the list and that we start enshrining some measurement and target setting around it.
Great, thank you all for that answer. We are nearing the end of our time together. We only have a few minutes left, so maybe I'll just ask each of you one final question. And we'll start with you, Monica. Same question for all of you. If you had one message that you'd like to leave for the audience, what would it be?
I think the biggest part is like we all play a part in how AI will be, implemented within our system, not just within healthcare. And it is about educating yourself and continuing to read, because as much as this watch list has been, developed in 6 months, it could change drastically, right? And so it's just about understanding and applying that knowledge and helping others to understand. I think is the biggest part for me. Education and awareness is key and critical.
Amol, any final thoughts from you?
For me, the final thought is, if you look back at healthcare in the 1960s, and then healthcare in the late 1990s, early 2000s, they're unrecognizable, the difference between them. So in the 1960s, we didn't have pulse oximetry. You couldn't measure the oxygen level of a patient just routinely. You didn't have a CT scan. You didn't have any of the basic technologies that drive healthcare today, MRI machines, all the imaging technology, all like healthcare in the 60s to healthcare in the late 90s. That's when all of the inventions that drove medical care today happened and were taken up. If you look at healthcare in the 1990s, so like take, a touch point for those of a certain generation, including myself, would be like the TV show ER, or the very early days of Grey's Anatomy, let's say. Healthcare in that day looks pretty similar to healthcare today. You have very similar sets of technologies, very similar. We've seen, don't get me wrong, we've seen important advances, mRNA vaccines, things like that. But we have not seen a paradigm shift in the way healthcare is delivered. And the same amount of time has passed between the 1960s and 1990s and between the 90s and today. Okay. I think we are faced today with the truly revolutionary set of technologies, so that if we look forward 30 years from now to today, healthcare will again be unrecognizable. And the opportunity is for us to incorporate these technologies carefully, safely, effectively. And it's why I think, an organization like CDA is critical, because the truth is, if we are being unvarnishedly honest, most of the evidence base for the AI technologies that are being propagated or advanced in healthcare today is far below the standard that we would hold a medication to. And if that's the case, we have to ask ourselves why. Why are we doing that? And how do we solve that gap so that we can safely incorporate these technologies? And the role of health technology assessment is so important, because we have very scarce, precious dollars to spend in healthcare. Let us not get dragged into the hype and wasting that on things. Let us invent the new world of rapid evaluation, of shared data sets, of quick embracing and evidence generation, but not lose the rigor. And let us use this crisis moment of geopolitics to hopefully accelerate this work so that Canada can play a leading role. It's critical for our sovereignty, not just for our opportunity. We shouldn't be reliant on foreign technologies in this space. So thanks so much for having me and for shining a light on this critical topic.
Final thoughts from you, Donna.
Okay, I don't know how I'm going to talk that, both Amol and Monica, but I don't want to repeat, because I do believe, I was thinking about the paradigm shift. And so for me, from a patient partner perspective, I think I agree with, it is going to look very different in 30 years. So the question is how we get there, and how painful it is, and how smoothly, and what that journey looks like. And no surprise to others, to everybody here, I do think that patient partners can play a significant role in that, in helping to do that. And I know there are a lot of people in the audience today that are, whether they're involved with technology or healthcare reform, because I don't think you can separate those two. I would encourage people to think about it's another resource in the piece to transition, because a lot of this, go back to, is about culture change and people change. It isn't that there's a piece of it that's the actual technology, but that's not the difficult part. So I think, and that's where patient partners can play a significant role. And I'll leave it there, since I see give you the last.
Yeah, and so with that, we're at the end of our session. I do want to thank everybody for attending the launch of our 2025 watch list. We do hope you found it informative. And of course, a huge thank you to our panelists for sharing your insights and expertise. Our hope is that this work will help health systems prepare for the rapid advances in artificial intelligence technology that we talked about today, and ultimately improve access to better care. And so we encourage everybody to take a look at the report and share it within your networks. And I think we have just one final slide. Just to say thank you again to everybody for joining us. If you'd like to contact us on social media, the details are on this slide, and the various platforms that you can find Canada's Drug Agency. And with that, I will close off our session today and wish you all a great day and a good rest of your weeks. Thank you so much.